how to manage. I'm going to cover massive hemoptysis, but I'll talk a little bit about the just regular hemoptysis. So we'll start with the case. 7-year-old female had 2 episodes of hemoptysis, about 50 to 100 cc's over the past week, comes in to the emergency room, and while waiting in the emergency room has another episode of about 150 cc's of hemoptysis. No distress, no fever, no sign of infection. Never smoked, has a history of sarcoidosis. Stable vitals are all stable, stats are good. When on examination, there's right lung base crackles. And when we looked at the X-ray, this is what you can see. There's right middle lobe, right lower lobe kind of infiltrate there, which you can see here too. And CT, of course, CT is done. Anyone from the emergency room here? ED, practice CT? Yeah. So I always say the 8th vital sign in the emergency room is CT chest, CTP. So anyway, this is good. So the patient got a CT, and as you can see, there's some calcified subcarinal lymph node there, right middle of infiltrate. We couldn't tell whether it was blood or whether it's pneumonia. And these are the representative cuts. So, question to you. We'll talk about what is ideal and what happened with this patient. So, A, admit to ICU, do an urgent bronchoscopy, call thoracic surgery, order more tests, or bronchial artery embolization. So, how many would go for A? All right, B. All right, so Dr. Brown, you were not able to convince them that they needed bronch. Call thoracic surgery, no. More tests like technetium scan, bronchial artery embolization. Right, actually, this is a very well-aware group. Yeah, the patient should go to ICU. Unfortunately, in this case, this patient actually went to the step-down unit, and because the vitals were stable, even though he was having massive hemoptysis. So the other question that we always come up with is whether it's hemoptysis or hematemesis. How do you figure out? Of course, hemoptysis is bright red blood, and it's mixed with frothy sputum. pH would be alkaline compared to if it's hematemesis, it'll be acidotic, dark red. You can see food particles. But even though occasionally I would have a case, it's very hard to predict whether it's hemoptysis or hematemesis. The other one that confuses us a lot is the epistaxis, because you swallow the blood or you aspirate and then you cough up and then you can't tell whether it's coming from. So sometimes you have to call ENT to figure out if it is from there, from the nose, or is it coming from the lungs. So quantify, and this is where still a lot of controversies. How do we quantify? Whether it's mild, moderate? These are all my cases. So this is patient comes in the in the clinic, and they cough up and they show you the tissue, this little cough there, blood there. Well, that's probably mild. The issue is not how much they have, but how much of blood is there over how long of a period. Moderate, there's no agreement, but sometimes we say about 20 to 200 ml in 24 hours. Less than 20 is mild. Massive would be at least 200, but I will go over this a little later. Usually about more than 600 cc's in 24 hours. So massive hemoptysis is it happens only in 5 to 15% of all cases of hemoptysis. And the mortality in this population can be as high as 80%. And that is, the rate of bleeding is more important, because a lot of times also what happens is I've done many bronchs, patients that has a lung mass, no hemoptysis, so we put the scope in and we see blood there. So a lot of times they are not able to cough up, expectorate everything that they have. So this was a study done in 1968, and what they showed was if the mortality, they calculated the risk of mortality. So if they had more than 600 ml of blood in 4 hours, that's 70%. If it is 4 to 16 hour of a period, 22%. And then if it's 600 ml, but if it's over 16 to 48 hours, the risk is about 5%. So As you can see, even at that time, we knew it's the rate that's important, not how much you cough up. However, any degree of hemoptysis causing airway obstruction that makes the patient unstable, requiring transfusion, respiratory failure, hypertension, can be massive hemoptysis or life-threatening hemoptysis. So why is that important? And sometimes I see this all the time in the ICU. Our patient comes in, residents and fellows are falling on the hemoglobin. Well, it's great for GI bleed, but for us, it's actually, I mean, on rare occasions, we need to follow that, but most of the time we don't. The hemoglobin doesn't help us much because by the time there is a drop in hemoglobin, the patient will be dead probably. And the reason being, if you remember the dead space, it's about 150 cc's. All we need is a big blood clot blocking this airway. And then that's it. The patient will die from asphyxiation. It happens, not always, I would say probably once or twice a year, we're doing a procedure. And then anesthesiologists will say, hey, we can't ventilate, take the scope out. Oh, if you take the scope out, then we'll not be able to suck the blood clot. So we have to educate them. So, and then we go in and we see like a big blood clot sitting there, we pull it out and then it's fine. So even a small clot, about 50 cc size clot, can cause asphyxiation. So hemoglobin monitoring is not important always. Let's look at the circulation. Where does the blood come from? So there are two circulations in the lungs. The bronchial artery circulation, bronchial arteries are a branch of aorta. So here's the right bronchial artery that's coming out of the aorta. And then the left bronchial artery, this is kind of flipped, the left mainstem bronchus. But there are also aberrations. There are different aberrations of where the bronchial artery comes from. About 1 to 2% of the cardiac output is going through the bronchial artery. So it's a high pressure system. So it is the systolic blood pressure that we have is still in the bronchial artery. Most of the massive hemoptysis is from the bronchial artery, as you expected. The other one is pulmonary arterial circulation. This is deoxygenated blood that's carried from the right to left side. It's low pressure, unless someone has pulmonary hypertension, which we will hear later this week. And the low pressure is 15 to 25 to 10 millimeter on average. And they form capillary and then anastomose and then go to the pulmonary artery, pulmonary vein. Now, most of the bleeding, this is the most common one, the pulmonary circulation that we see, not the major ones. And I'll have some of the common causes of hemoptysis that we see in our practice is lung cancer, cystic fibrosis, if you have a cystic fibrosis practice, bronchiectasis. Of course, you do a major procedure, then procedural complication is there. Aspergillus fungus ball, I probably see once every year, one case, not a whole lot. Bronchiectasis is very common, and that can cause, and these are all, usually all of them are from pulmonary circulation. So 90% of the bleeding that happens with the massive hemoptysis, because it's a high pressure system, it is coming from the bronchial artery. 5% can come from aortobronchial fistula. I actually have not seen one. It's just in the book. And then 5% comes from, this is massive hemoptysis. I'm not talking about all the hemoptysis. And so AV malformation, we have a HHT center, so we do see a lot of hereditary hemorrhagic telangiectasia patients that get coiled. Lung abscess can cause bleeding too, and if there's a necrotic pulmonary artery, we don't do the PA catheters. I don't know, have any of you done PA catheters? Way back? You still do? Okay. I did during my fellowship in my practice when I was in Ohio, I did probably 3 to 5, and then I haven't done one since I moved here 5 years ago. So we don't do it, but if the PA catheter is too far out and you inflate the balloon, that can rupture, and I have seen a case of that. Here's one of the patients that we had lung cancer, and you can actually see the pulmonary artery here. If you look carefully, see that it's a contrast CT. And you can see the vessel there. And so this patient came in with sentinel bleeding, was in the ICU, and then they called us. We did the bronch. We saw blood pulling in the cavity from the right side, right main. I could not get in there. There's no way we can get there. And we looked at the CT even carefully, and as you can see here, there's one cut. Now remember, these are 3 millimeter cuts. It's not the high resolution 1 millimeter cut, but still you can see a blood vessel going through the cavity. We called for IR to do the bronchial artery embolization. They could not, and literally the patient bled to death. We couldn't do anything. He was in front of us in in 2 days, 2 days after. So even pulmonary artery bleed can cause massive bleed with a fatal outcome. I was in Ohio, like I said, and we used to see a lot of histo. And the histo patients with the complications would come up with a broncholit. And here's one patient that came up with a large broncholit and was located right near the pulmonary SPC and esophagus vein. And here's we took the stone out. So, and then we cauterized the area with EO laser. The bleeding was controlled. It was not a massive bleed. It didn't sustain for a long time. So now the question, going back to our patient, the patient had another 50 cc's of hemoptysis. Remember, the patient is in the step-down unit. What would you do now? A, bronchoscopy. Anyone? Well, patient's already admit to MICU for this particular patient, so we should go to MICU. Everybody agrees. Should we send the patient for bronchial artery embolization? Not yet. Okay. Thoracic surgery, probably not. We need to secure the airway because now it has 50 cc's. All the vitals are stable, so that's what happened at this point. The patient went to the ICU, and then we were called for bronchoscopy. We did the bronch. Before we did the bronch, we put the intubate. So first was trying to do it with the laryngoscope. There was just so much blood there in the oral cavity, you can't even see the airway. So one trick that I've learned from peds patients is if you can't see anything, if you press on the stomach, sometimes there will be a bubble, and that kind of gives you a clue where the airway might be. So anyway, we found it and then intubated over the DL, direct laryngoscopy. And then as soon as we put the tube, the scope in, there was blood all over. So we'll go over this. This is the principles A, B, C, D, as I called airway. So of course, airway. Block the bleed, control of hemoptysis, and then we look for a definitive therapy. So how do we intubate? This is where I tell everybody, if a patient is in the ED, they will usually put a small, like 7 ET tube because it's much easier to pass it. But we prefer to have at least a 8.5 or larger ET tube. And I'll show you the reason why. Number one, there's more blood flow. There's always room for ventilation. If I need to put a blocker catheter, I can put it through there. And when you put a blocker, we'll see later, we need a larger lumen. Do not intubate nasally because it'll be a small ET tube and the patient clots, if there's a clot formation, that tube can get blocked. So do not intubate nasally. And always, it's much easier you can intubate, load it on the scope and then intubate over a bronchoscope. Pulmonologists or intensivists or anesthesiologists can do that as well. If the bleeding site is known, then lateralize, and that could be from the history. Like let's say the patient comes in with the lung mass on the right side. We don't have a current CT, but we assume that it's if they can bleeding, it's probably coming from the right side. If you have CT scan, then we already know. Or if we had done a bronchoscopy and we saw bleeding from the left side and now bleeds again, so we assume that it's from the left side. Bleeding site dependent, so we're trying to isolate the normal lung from the bleeding lung. Of course, we have all agreed to monitor these patients in the ICU. Remember, the pulmonary vascular circulation, it's a low pressure. So oftentimes, if you go up on the high PEEP, and if you know by now what is your etiology, if it's pulmonary circulation, or is if it's not bronchial, if it's one of the etiologies that we talked about. In those cases, actually, you can go up on the PEEP to 16, 18. Oftentimes, that will actually slow down the bleeding. And then we'll do the selective intubation or block it. So the first one, so this one is the endotracheal intubation. We always hear either you can put the ET tube into the right main or left main. Going to the right main is much easier. You just slide it in, you'll end up in right main. Going to the left main is not that easy, especially when you have a larger ET tube. Even with the scope, it is not very difficult. So if you really have to intubate on the left side, over a scope is better, and probably at least an 8 ET tube would be better. And then we can also always pass the bronchial blocker catheters through this. So here's one patient, one example. We will talk about the double lumen tube. This is the principle of the double lumen tube. So when you have a anesthesiologist like the left-sided double lumen tube, because it's much easier. Left side, we can just pass it on to the left. There's one balloon here, one here, and then we isolated the lung. Right side, on the other hand, is difficult because there's a right upper lobe, and we can always block that. So pretty much everybody, but even with that, you have to position. It takes about minimum with the best anesthesiologist, it'll take about at least 10-15 minutes to confirm that it's in the right place. So here's the double lumen tube. So this is the right-sided. So this is the opening for the right upper lobe. This is right lower lobe, and this is the tracheal cuff. Left side, this is the cuff in the trachea. This is in the left main, and then there's a hole here, so we can isolate the right and left lung. This is great. Worse for anesthesiologists in a elective condition, but in emergency, this is not the best choice. I would not even go for this. Here's an example, the reason why. This is one of the patients that was admitted to our ICU, came from surgical side, double lumen tube was inserted, and I don't know if you can read. It says here, no suction. They said no suction here. So, of course, there's no suction. And this happened about 2 years ago. We couldn't ventilate. And as you can see, when I cut the ET tube, it's just quite large clot there. So these lumen, remember, the regular ET tube is about this size, and we divide it into two, so it's even smaller. So it's great for selective intubation, selective ventilation by anesthesia, but not for hemoptysis. And I know a lot of, if you review the literature, it does recommend double lumen ET tube, but my recommendation is not to even use it, especially in massive hemoptysis. There are other options that are much easier to use. So this is a armed blocker catheter. It's there's a balloon at the end, there's a loop, and we can put the loop around the scope and then pass it. So here's the ET tube. And then we can pass it either on the left or right side, guided by the bronchoscopy. And here's the actual arm blocker catheter. We see the balloon. There's the small loop. We put it around the scope. And then as we go in, we have to pass both of them at the same time and then go to the left or right. And then we can do selective ventilation. Here's one of the patients that we did. I think it's so we didn't have the arm blocker, so we just had a regular balloon. I just put the regular balloon there. And then here's the example of the arm blocker in the right main. And you can see it here. This is the arm blocker going in. Now, the problem is, like I said, we have to have a large ET tube, and oftentimes it's not possible. So I had a patient with tracheostomy. So we did the bronch over the tracheostomy and then passed the arm blocker through the nose. And it worked okay. We kind of had to guide it here, and it just stayed in place. So arm blocker works great. We found this is another one, and it's even better and easier to use. So remember the heart cath, the cardiac caths, we always have the tip is curved, and that's what they did here. Let me see if the video works. So here's the scope going in first through the ET tube, and then we have this is called a uni blocker, and as it goes out, but through the ET tube, we can see there's a curved tip, and we can actually move it left or right. All you have to do is just roll it, and then you'll go to the right or left main. Now, we can't go beyond the lower lobes. That might be a little difficult with this, unless you have a scope. So here's the example from the bronchoscopic view. And so the balloon's there. All you have to do is just rotate. There's no we just need the bronchoscopy for vision, but not to guide where to go. And then we can go left or right. And this is a great tool. It costs about $400. So CT chest imaging, when I started to talk, we would always get the X-ray and then chest CT was often not done, or we had to call for CT. But CT is actually pretty good. Not only it localizes, and compared to bronchoscopy, CT scan actually can identify, especially if you have a contrast CT, can identify the bleeding site about the same at the same rate. You can also see the cause of bleeding, like if there's a lung mass or lung abscess or aspergillus fungus ball. It can oftentimes replace bronchoscopy as a first-line approach if it's done early. But then once someone has massive hemoptysis, patient may not be stable also to get the CT. And in that case, I'd say bronchoscopy would be the first option, especially if the patient's in the ICU. And there are different bronchoscopes. We like the one that has the largest channel, working channel, because we need to suction blood out. And that's about 2.8. We call it therapeutic scope. And most of the time, so when you have massive hemoptysis, we go in and we'll see blood on both sides. Then we suction clean and then try to identify where it's the active bleeding coming from, left or right, and then we can lateralize. It's also helpful if you can lateralize before we send the patient for bronchial artery embolization, because then they don't have to put the dye in both arteries, because then we already told them. So they can actually go to the right or the left bronchial artery. And then my book, no matter if the patient has mild hemoptysis, like the picture I showed you, just coughing up a sputum mixed with blood, I would say we need to do a broncho. The question is, how soon do you want to do? I tell everybody in my residents and fellows, like, we have to do it within 24 hours at least. Now, if it's a stable patient, unstable patient, as soon as possible. One thing that I learned from that patient when I was trying to do the DL, it's much easier to actually intubate over a scope, provided you find the airway. So actually, oftentimes we use the DL, look at the airway, and then pass the scope, and then slide the ET tube over it. Now, we do have disposable, we are depending on the reusable bronchoscope for a long time. So that was another issue, because you had to carry the big tower. Now we have these disposable scopes. That is the monitor. I mean, you can just carry it. And this is all the current varieties that we have in market, 5 different kinds of disposable scopes. And in our ICU, we actually have those down. We don't have to hold that tower. We need that only on special occasion. You'll also hear what about rigid bronchoscopy, and you'll see in the algorithm, it does mention rigid bronchoscopy. The rigid bronchoscopy is good. So here's when you have to do the rigid bronchoscopy, remember we have to have the patient on general anesthesia. So oftentimes we can't even take the patient to OR or get anesthesia in the ICU for general anesthesia. It is great to extract large clots, but there are other ways, like I'll show you later, we can actually even pull out a large clot. And the other thing, this is most helpful if there is an endobronchial tumor mass. That's where, with a rigid scope, we can actually scoop it out, control the bleeding. We use EAG laser, which is actually great compared to other tools, because not only does it core out the tumor, it cauterizes the tumor, it also vaporizes the bleeding vessels. So there's no vessel, it doesn't bleed. So we can do that. Now, honestly, for any patient, all the massive hemoptysis that I've seen, I don't think I've used it for any of the massive hemoptysis cases, but probably the moderate hemoptysis cases that happen. And this is the difference. So this is the rigid scope tip. It's about 8 to 10 millimeter in diameter. We can actually pass a regular flexible bronchoscope through that. And these are the different size forceps. Now, oftentimes we're tempted to, if you see a pot, grasp it with the forceps. The problem is you'll never be able to grasp it because it's soft. It actually cuts through, so you cannot pull out clot that way. Suction is one option, and I'll show you later. So there's a patient that we were talking about. We did the bronch. We noted the bleeding from the right lower lobe, right middle lobe, the right upper lobe, and the left side was normal. And we did argon plasma coagulation. It was just cauterized the bleeding point. Patient was intubated and then transferred to MICU again. So bronchoscopic management, and this is more common that happens when you have a patient in the during the procedure, icicles in it. It works. The problem is it's not easily available. You have to get it and to cold the ice. We have ice there, and I don't know if you noticed. We put a bag there. So we had one case where the tap water was contaminated, and then the syringe was put in. So now what we do is we'll have the ice, put a bag, and then the saline in the ice goes in the bag. That way it's not contaminated. And it works most of the time. We start with this. Epinephrine, topical epinephrine, 1 in 10,000 dilution. So you can just get one of these and mix it with the saline, and that'll work. We just spray like 2-3 cc's on the. It works better if it's a mucosal bleed. So there's a concern that if you put it in tumor mass, it can get absorbed and the patient can go through hypertensive crisis. I have not seen that, but you'll hear that oftentimes. Vasoconstrictors, I have not used it, but you need to know there's ADH derivatives, terlipressin or ornipressin that can be used. It can be used topically, just through the ET tube, or given IV. We do that for GI bleeds. Tranexamic acid, this is used commonly for GI bleed, antifibrinolytic. It can be given IV or endobronchially. Competitively inhibits plasminogen activation, and we don't have much data on massive hemoptysis, so I haven't used that. Fibrin clots, you may have heard that. I will say it doesn't work. The clot just gets, so basically you get the fibrin and the serum in 2 syringes. You push the planter, it comes out and it forms clot immediately. But when it's bleeding massively, it doesn't work. Topical cellulose mesh, it's been described, and you have to actually take the mesh with the scope, hold it forces, and then go in. Hot therapies, like I said, the egg laser, argon plasma coagulation, those are all good options. This is the best option in the clot removal, cryotherapy. So you put the cryoprobe, and we will have a demo of the cryoprobe here on Wednesday. We can actually freeze the clot and then pull out this rather than suctioning. Like I said, biopsy forceps does not work. This is the best way to remove clots. All right, we'll go back to our patient. So remember, she had the bronchoscopy downwind back, and then 2 more episodes of bleeding happened after we did the bronchoscopy. So now what? Next best step. How many would go for A, rigid bronchoscopy? No. Surgical resection. External radiation. I have seen that happen, external radiation. Bronchial artery embolization. All right. I don't think I needed to do this talk. Everybody knows how to manage. Yeah, bronchial artery embolization. That's exactly what we did in this case. So in the bronchial artery embolization, remember it was on the right side, right middle lobe. When they put there's a fistula between the bronchial artery and the pulmonary artery. And so it was coiled, and it was coiled right here, and then the bleeding stopped. So it was described first in 1977 by Dr. Remy, and in immediate success, if they can localize the bleeder, is 80%. But over time, it doesn't work. It should not be 1 or 2. It's 10 to 21% recurrence in 1 month. Gel foam powder can be used. Those are other substances. The complications are if they backtrack. Remember, the spinal artery arises from the same similar area where the aorta is. It can actually block the spinal artery, and that can cause symptoms. T fistula can happen. Ischemia, bowel ischemia can happen. Surgery. Mortality is about 34%, especially if it's emergency surgery, because remember, if it's bleeding, you have to cut, and then there's bleeding from there. Oftentimes, in old days, it was a great option, but now that we have rigid and other tools, it's much easier to use them. And surgery it could be an option if it's uncontrolled massive hemoptysis, and we know where it's bleeding from left or right. And then if the bronchial artery embolization fails, then that could be an option. But there's no randomized study comparing the surgery with the medical management. Here's another one. Have any of you used a recombinant factor 7? You used? Okay. So this is, I have been using it for about 10, it does probably like every 2 years we will need a case. If you have diffuse alveolar hemorrhage, this is actually great tools. So this is recombinant factor 10, costs a lot, and we can put it in through the ET tube. And then I had a patient who was on ECMO and bleeding, and then we went into each lobe and then sprayed it. We have to talk to the pharmacy because they have to dosage. So this is a diffuse pulmonary hemorrhage, and we put in the recombinant factor 7 in each lobe rather than spraying it in the trachea, because then it would stay mostly in the dead space, and actually the bleeding stopped. Okay, one more update. So patient went home, and then after 2 months comes back with another bleeding episode. This is one patient that I had in fellowship, and pretty much everything that we need to do through the on the algorithm for hemoptysis management happened with this patient. So this time, no mistake was made. Patient went straight to the ICU. Endobronchial control done with the Fogarty catheter. Bronchial arteriogram done again. This is the second time, and failed the second embolization. So now what? What would you do now? Someone? I didn't have any choices. So this is so at this point, right middle lobe, we knew it was right middle lobe. And I remember actually I went down to the pathology that we actually cut down, because remember we showed you the calcified lymph nodes. So we were thinking that the calcified lymph nodes may have eroded to the pulmonary artery. And there's one stone, I think, not that one, somewhere. There's one stone, but it was not on a blood vessel, so we don't know what happened, but patient had lobectomy. How are you doing on time? All right. Okay. I'll go through another case then. This happened recently. We had a patient I'll just give you, before we look at the CT scan. So this patient had infiltrate in the left lower lobe, and the suspicion patient was on steroid, was that opportunistic infection. So we were called for bronchoscopy to get a specimen, just a simple BAL bronchoscopy, which takes about 3 minutes. And so my fellow and we were in the room. So if it's a BAL bronchoscopy, we usually do it with moderate sedation, unless it's EBUS or something that takes longer time. We will use general anesthesia. And this is the CT on the patient. So we looked at the CT before. I'll go, hopefully you can see the lung view and the mediastinal view on the left side. So it's normal so far. And as we go down to you'll notice here. So there's the infiltrate there. And it was more dense. So we did think about whether it's blood, but the patient did not have any hemoptysis. And so we put the scope in, and we didn't see anything either. And so anyway, I'll come back here. So we did so this is the bronch. When you're going in, this is the beauty of doing a moderate sedation bronchoscopy, because we can look at the vocal cords. One thing we noticed, which was kind of unusual, the left vocal cord was not moving. The right one was moving. Well, we see it, and we see that often. Didn't pay much attention. Did the bronch. This is the left main stem. It's narrow. There's like a little bit of necrotic material there. There's more close-up view of that. There's necrotic material there. So the fellow, we went into the right side, examined the right side. As soon as we passed the scope to the left side, there was massive bleed. I mean, massive. I have never seen that. This patient had to go through a massive transfusion protocol. And now let's look at the CT now that we know the history, and I will try to stop it. Sorry. So we look carefully on the left main, right about here. So when the left main comes, see the pulmonary artery, the left pulmonary artery, and this is all necrotic material. So we did not have a patient's family refuse an autopsy. So patient, it was a fatal outcome. So what happened was probably we put the scope in and then suctions necrotic material, and the pulmonary artery was right there. It was a disaster. Patient got like 6 units. We coded for like 40 minutes and couldn't survive, get him to survive. So that's why I think I made a policy in my mind and my practices always, if we have hemoptysis, this patient didn't have any hemoptysis. It was just a simple BAL bronchoscopy, but the patient, and this is one of the first patient that I ever saw has it. But look at the CT, and in retrospect, that was the idea. Could we have prevented it? Well, there's no way of knowing. It's we discussed whether anesthesia would have been better, so you have an ET tube. Well, in this case, actually, we had the scope, so we immediately put the patient on left lateral condition because we knew what the CT findings were, and then we intubated. The patient was in lateral condition. We didn't even have to get the patient supine, intubated over the bronchoscope, and then I passed this ET tube onto the right side. But what happened was, I think in retrospect, the patient probably bled into the mediastinum. ET tube was secure because we were bailing the right lung. But it was just, and then they were doing CPR. It was just, whatever blood was given, it was just going, and then about 40 minutes later. So things can happen when you least expect. And so in conclusion, stabilize the patient. If the patient is unstable, intubate, transfusion, resuscitate blood transfusion, intubation for better gas exchange, suctioning, and larger ET tube is better. We can do local therapies, selective intubation, left or right, like we went over. We can use the blocker catheters. So bronchoscopy is mandatory. And I tell everybody, so no matter what kind of hemoptysis it is, we should do a bronchoscopy. Especially the massive hemoptysis usually has a sentinel bleeding that'll go on for like spotty bleeding for a couple of days or weeks, and then it'll just happen. Localize the specific site, identify the cause of bleed, and then blockage. Endobronchial blocker, I showed you 2 of those. Those are great. If bleeding site cannot be localized, then we can do bronchial artery. Remember, they have to fish out right or left. There's this technetium scan that we use for GI bleed. That doesn't work for lungs unless there's active bleed going. And if there's active bleed going, we probably have already found it with the bronchoscopy. Rigid bronchoscopy is plus minus. If it's a mass, I think it works great. But if it's bleeding from the lung abscess from the right lower lobe, I won't be able to do much other than tamponading, which I can do with the balloon with the flexible scope. And surgery only if every option fails. You all know what this is, right? This is the iron lung. So I was at Ohio State before. We had actually one in front of our office right there. They were trying to scrap it, and we're just looking at it, keep leaving it there. It's still there probably. Well, thank you, everyone. And if you have any questions, I'll be happy to answer any questions.